I could ask this to any of you, but we've heard a lot of discussion today about the collaborative care model. Could you just describe in a little more detail, get down in the weeds a little bit, what is the collaborative care model and how does it work?
Happy to, though, but so the collaborative care model basically puts a behavioral health care manager in the primary care practice. So it's a person to help the primary care doctor be able to carry out the additional procedures that are necessary to assess, diagnose, and treat mental health and addiction disorders within primary care. So it's just like the doctor now has a nurse, and he can go and take your blood pressure, and he can take your temperature, and that helps the doctor out so she can do her part. The behavioral health care manager basically extends the ability of the primary care provider to do those in-office concerns, and it works just as well with virtual presence through telehealth as it does through in-person. And then there's also a psychiatric consultant to help with medication questions. And that psychiatric consultant reviews what's going on, is there to help support the primary care doctor, so the primary care doctor can treat upwards of 70% of mental health conditions can be treated successfully with the same or better outcomes than specialty care in primary care with those two supports. And then the other thing is they have special data systems to track people, because what happens is if you have depression, sometimes you don't take your meds, sometimes you don't come back to your appointment, and someone needs to make sure you don't fall through the cracks. And so the registry and the tracking system the care manager uses to make sure the person does not fall through the cracks.
So this obviously involves additional providers and additional staff in a traditional doctor's office, if you will, correct?
I would say, sir, that Senator, it's a redeployment of staff into them. We don't need more people to do this. We need them redeployed into primary care settings.
All right, and so does this mean, though, that there is a need for us to change either the mandates or the incentives or what have you in the insurance markets? Or does it mean, and I think Dr. Raslip talked to this, that we need to change the reimbursement policies in Medicare and in other government-run healthcare systems? Is that piece of it, the finance side of it, something that we need to be able to tool up?
There could be some tweaks to that, but basically once it's up and running, payment mechanisms in commercial care and Medicare and most Medicaid plans currently cover it somewhat adequately. But what they don't cover are the startup costs, and they don't cover the technical assistance needed to convert a practice quickly. So it's really getting over that hump of startup that we require additional investments.
Well, thank you.